Good afternoon, all. Welcoming all of you to our IC. The title is Mastering the Myopic Macula, and let's have a detailed look into the different types of macular lesions in myopia, along with their medical and surgical management. This IC is sure to benefit the postgraduate students for their exams and a refresher course for practicing ophthalmologists. So we have a small switch in the topic order. First, Dr. Divya will be speaking on anatomic peculiarities in myopia. Part B, the domes, the dips, the cavitations, and the pits. Welcoming Madam on stage.
Okay, thank you very much, Dr. Anjana, for giving me this opportunity. So these topics given to me are all structural changes which are seen along with pathologic myopia. So first is posterior staphyloma, and posterior staphyloma is considered to be the hallmark of any pathologic myopia. And it was described by Spade as an outpouching of the wall of the eye that has a radius of curvature less than the surrounding curvature of the wall of the eye. So as we already know, the scleral shell in highly myopic eyes has increased elasticity, and they, over a period of time, tend to expand gradually and they become thin. So many theories have been postulated for this staphyloma. One is the thinning of the sclera and the scleral protrusion along zones of closure or the embryonic fissure. The second one is choroidal thinning, causing scleral thinning and leading to staphyloma. But these theories do not explain why staphyloma also happens in non-myopic eyes. So we have to look at external factors. This is some new thing which has been proposed, that the superior oblique and the inferior oblique muscles, which insert at the posterior part of the sclera during torsion, can cause some amount of outpouching of the sclera. So Curtin described the staphylomas in detail, and he classified them into 10 different patterns, 5 primary and 5 compound. And the primary staphylomas have been divided into 1 to 5 types. The first is posterior pole, then second is one involving only macular area, third is peripapillary area, fourth is fundus, which is nasal to the disc, and fifth is area below the disc. And when we see compound staphylomas, they are a mix of 2 types of primary staphylomas. There are various methods to detect. It is very easily detectable by a routine indirect ophthalmoscopy. Stereoscopic fundus photograph can be used to document. B-scan, on B-scan it is seen as a shallow outpouching compared to a coloboma, which has a very sharp outpouching. Then SD-OCT and SS-OCT. The ultra-wide field fundus photography is considered to be the gold standard to diagnose staphyloma. 3D MRIs are used in research purposes. So in this photograph, we can see only the posterior pole is seen in the fundus photograph, whereas in the wide field fundus photograph, the edges of the staphyloma are clearly and well demarcated. 3D MRI was described in some studies where they showed that after studying the staphylomas in a axil length with more than 30 mm, more than 50% of eyes have staphyloma. And they had a new type of classification, that is wide macular staphyloma or a narrow macular staphyloma. Why do we need to know about them is that the presence of a staphyloma has worse structural and functional outcomes in high myopia with more visual impairment. Chorioretinal changes are more significant in these patients with staphyloma. It is associated with high degree of myopic maculopathy, and they are also associated with myopic neovascularization. The next one is dome-shaped maculopathy. This is reverse of a staphyloma, where we have a convex protrusion of the macula detected on OCT. And this also is a result of asymmetrical scleral growth. It has been studied by many people in earlier years because the EDI OCT and the in-depth OCT was not available. The pathology was not well known. But nowadays it is said that there is increased subfoveal scleral thickness at the part of the posterior staphyloma, and there is asymmetrical scleral thinning. So 3 types of anatomical domes have been described on OCT: horizontally oriented dome, round-shaped dome, and vertically oriented dome. The horizontal oriented dome is more commonly seen. So always in case of myopia and all, when we are taking an OCT, remember to take the horizontal and vertical sections also. So even in the vertical sections, we can have new findings in regard to pathologic myopia. In a horizontal oriented dome, the vertical scan will show more protrusion. In a round-shaped dome, this is the second most type of dome, where both horizontal and vertical will show convex protrusion. Vertically oriented is the least common, where in the horizontal scan itself you can see the protrusion. So there are some complications with dome-shaped maculopathy. It is known to cause shallow subretinal fluid. It can cause incidence of CNVM, but the incidence of CNVM is said to be independent of dome. It is already associated with high myopia. This dome-shaped maculopathy also has a protective effect. It can act like a macular buckle with lower incidence of foveal retinoschisis. So SRF in the DSM has a variable range. It has been reported to be around 66 to 1.8%, but always rule out an associated CNVM if you see an SRF. And for the SRF also, there are multiple hypotheses. One is the hypothesis similar to CSR, that there is a thick choroid at the dome which is causing the fluid. The other one is similar to nanophthalmus, that there is more thickened sclera which is impairing the flow of the choroidal fluid. So various treatment modalities have been tried in the lines of CSR for this dome-shaped maculopathy also, but many times it is resistant to treatment and it keeps on recurring. The CNVM, which will be discussed again, I think later on, I will just go through it fast. It is independent of the dome-shaped maculopathy, and again, it is a type 1 CNVM, and intravitreal anti-VEGF is supposed to be more effective. Then is the intrachoroidal cavitation. This is a morphological feature which is outlined by OCT. It was first described by Freund et al. What happens here is it is characterized by a presence of hyporeflective space underneath an unaltered RP. So that underneath the RP, that hypo area which you see in the peripapillary area, that is the intrachoroidal cavitation. The overlying retina, RP and Bruch's membrane are intact here. And this happens because of expansion of the distance between the inner wall of the sclera and the posterior surface of the Bruch's membrane. On fundus examination, how can you suspect this is when the red star in the photograph, you can see the red marked areas are the intrachoroidal cavitation, well circumscribed peripapillary yellow-orange like lesions. And when you take an OCT through that, you can detect this intrachoroidal cavitation next to a myopic conus. Uncomplicated cases do not cause much visual acuity problems, but they are known to cause some visual field defects. The last of this is the myopic macular pit, where it is characterized with a high myopic patient with a deep trench-like excavation near the macular area. You can see the red arrow pointing in the fundus diagram, an oval-shaped area, that is a macular pit. And on the OCT, you can see that there is a trench-like area with entire thing is dipping down like almost like a coloboma. But there is no RD or any traction seen at this area. So this also happens because of continuous increase in the axial length in pathologic myopia, causing choroidal ischemia, leading to retinal and choroidal atrophy. And eventually the IOP itself can cause to formation of these type of pits. Why we have to know about these pits is very rarely during a retrobulbar anesthesia, you may have scleral perforation if you pass through this. So thank you very much. And on behalf of the organizing committee, I would like to invite you for Ignite 2025, happening on January 4th and 5th at Kochi. Thank you.
Thank you, Divya, for this. I think you have finished 2 minutes ahead of time, so we can have some questions from the... Do we have anything to discuss? So what is the role of, like, if you have a fluid in dome-shaped macula, what is the role of OCT angiography? How will you use OCT angiography? Can it be used to identify CNVM, or how do you go about it?
To look for the choroidal neovascularization if it is associated, and then we can predict that it will have a better response with giving anti-VEGF rather than a plain only SRF with associated with dome-shaped maculopathy.
What are the problems, like routinely when you use OCT angiography, what are the problems that you face?
The artifacts, I think because of the deep curvature difference in the eyeball, the correct segmentation may not happen in these cases.
Okay, then we'll have the next talk. That's anatomic peculiarities in myopia, optic disc, and peripapillary changes in myopic maculopathy. Anjana, Dr. Anjana.
Good afternoon, all. My talk is on myopic retina part A. That is now. First of all, we'll go to the definition. In this session, we are mainly dealing with high myopia. So high myopia is defined as the presence of a highly negative refractive error in the range of -6 and more of diopters with an elongated axial length more than 26 millimeter. The terms high myopia and pathological myopia are often used interchangeably, but these two are not the same. The basic difference is that in pathological myopia, the elongation of the axial length is happening along with some pathological change in the posterior fundus, such as a posterior staphyloma. Now coming to the optic disc and peripapillary changes, basically we have two types of macro discs in myopic eyes. The first is the primary macro disc occurring in non-highly myopic eyes, and these are mainly circular in shape. The size is not markedly associated with refractive error or axial length. These eyes do have large globe diameters, mainly in the horizontal and vertical direction, without much elongation in the sagittal globe diameter. The basic large disc size is because of an increase in the number of rods and cones, the number of RP cells, number of nerve fiber layers and the ganglion cells, and the number of laminocribrosa pores and the total pore area. Now coming to the secondary macro discs, these are mainly seen in pathological myopia. In pathological myopia, the disc size increases very markedly with increasing refractive error or axial length. The disc appears oval shaped and obliquely rotated, and this is also because of an ophthalmological artifact happening because of the increasing distance between the optic disc and the fovea. So this causes the optic disc to get pushed more nasally. Therefore, when we are viewing the optic disc ophthalmologically, the view is not directly perpendicular but obliquely directed, and so we have an apparent oblique appearance, and we have an underestimation of the horizontal disc diameter happening. Now about peripapillary atrophy, it is because of the chorioretinal thinning and interruption of the RP in the peripapillary area. We have two zones. First is the beta or the inner zone, and the alpha or outer zone. In the alpha zone, there is irregular pigmentation, and this is in contact with the normal retina exteriorly and with the beta zone interiorly, and if the beta zone is absent, with the peripapillary ring. Now about the beta zone, here we have the larger choroidal vessels and the sclera visible. This can occur in normal eyes as well, and also in glaucomatous eyes. Now, recent histological studies have added two more layers, that is the gamma and the delta zone. So, basically in alpha zone, there is RP present, and in beta zone, the RP is absent, only the Brooks membrane is present. In gamma zone, the Brooks membrane is also absent, and there is normal thickness of the peripapillary scleral flange, and in delta zone, there is thinning of the peripapillary scleral flange. Now, coming to the glaucoma-related aspects of the tilted discs, myopic eyes are very prone for developing RNFL and axonal loss, but the problem is that when evaluating these patients, the glaucoma evaluation of this patient is difficult because of the alteration of the RNFL peak locations happening, and because of the changes in the macular ganglion cell IPL distribution. So both diagnosis as well as monitoring of the disease progression becomes difficult, and also sometimes these eyes may not be having a glaucomatous change, but the presence of the peripapillary atrophy can give rise to this arcuate scotoma and ring scotomas. So these eyes may sometimes be unnecessarily treated for glaucoma and may be put on anti-glaucoma medications. Now, the ocular alterations occurring in pathological myopia in the macular area is the myopic maculopathy. So, coming to an important classification, that is a meta-BM classification. Myopic maculopathy is classified into 5 categories: 0, 1, 2, 3, and 4. 0 is a normal fundus, 1 is a tessellated fundus, 2 is diffuse chorioretinal atrophy, 3 is the patchy chorioretinal atrophy, and 4 is the macular atrophy. And we have 3 types of plus lesions as well. One is the myopic CNVM, next is the lacquer cracks, and third is the Foster spots. Tessellated fundus, as we all know, is basically because of the chorioretinal thinning that is happening, and therefore we have a lesser number of melanocytes, and therefore the choroidal vessels are better visualized. This can occur in normal eyes as well here, but here what is happening is that the thickness of the choroid and the retina is relatively normal, but the decrease in number of melanocytes is giving rise to the stygroid or tessellated appearance. The RP attenuation around the disc is the peripapillary atrophy. Now about diffuse chorioretinal atrophy, here we have a yellowish appearance of the posterior pole, and the choroid is severely thinned in these eyes, and this changes initially begin around the optic disc, and then as the patient ages, the atrophy progresses and the posterior pole is completely involved. Most of these eyes have associated posterior staphyloma, and age and axial length have been recognized as the risk factors. Now next is patchy atrophy. Here we have patchy areas of RP and chorioretinal thinning rather than a diffuse thinning, and the macula is in this picture we can see that the macula is more or less spared. Only focal areas of atrophy are there. Now macular atrophy proper, this is the category 4 as per the meta-PM classification. The OCT is showing severe thinning. There is relatively no RP, and the sclera is seen in direct contact with the retina. Now about the plus lesions, the first is the myopic CNVM. This is going to be dealt separately in the coming session. I'll just present everything in a single slide. This macula is seen to have edema, hemorrhages and exudates, and the infrared image is seen, and the OCT sections we can see the presence of the SRF and the subretinal hyperreflective material, and the octa is showing the complex, and the FFA in the late phase is showing leak from the CNVM. Now the other second plus lesion, that is the lacquer crack. Lacquer cracks are seen either as vertical, horizontal or crisscross lines at the macula. These are basically breaks occurring in the RP Bruch's membrane complex, and a newly formed lacquer crack can sometimes present as a macular bleeding. And that's why, so whenever we see a macular, myopic macula with blood, this need not necessarily be from a CNVM. It could be from a lacquer crack also. So when the hemorrhage clears, the lacquer crack is visualized. So a lacquer crack along with some RP of atrophic areas at the macula is seen. This is better appreciated in the infrared image. Lacquer cracks may be a foci for future CNVM as well, and over time these breaks can expand and lead to macular atrophy. Now third type of plus lesion, that is the fugue spots. Fugue spots, also called Foster fugue spots, is an area of RP hypoplasia occurring as a response to previously regressed CNVM. The sequelae of events projected in a single slide. Basically, sometimes if the eyeball is not elongating anymore, the tessellated fundus remains as like that, and progression can be either in the form of lacquer crack at the macula, which can then give rise to myopic CNVM, and this can later go for atrophy or scarring, and diffuse choroidal atrophy can sometimes further progress and lead to patchy atrophy, which can then coalesce and give rise to macular atrophy, or straight away from the diffuse atrophy a macular CNVM, later on leading to atrophy. Lacquer cracks can also directly be a source of macular CNVM. Next, about the ATN classification, that is 3 components: A for atrophy component, T for tractional component, and N for neovascular component. Atrophy component is same as per the meta-PM classification, so we will deal with the tractional and neovascular components. Tractional components, we have T0, T1, T2, T3, and T5. In T0, there is no macular schisis. In T1, there is inner or outer foveoschisis. In T2, inner plus outer. T4 is a full thickness macular hole, and T5 is a macular hole RD. So inner means it is the IPL, GCL, and RNFL getting involved, and outer is the OPL and ONL getting involved. This is a cross section across the superior macula showing outer and inner atrophy. All these topics are going to be dealt in detail in the subsequent slides. So under patient with a macular hole RD. So it is at T5 as per the ATN classification. This topic is also going to be dealt in very detail in the subsequent sessions. Thank you so much.
For the detailed coverage of myopic changes at the posterior pole. So we'll have next Dr. Kiran speaking on myopic CNVM.
Good afternoon, and thank you for this opportunity. My topic is myopic CNVM. Anjana gave a very good introduction to this topic. Myopic CNV is the second most common cause of CNV after age-related macular degeneration. It is seen in 5.2 to 11.3% of pathological myopia, though it can be seen in any degree of myopia and without typical myopic or degenerative fundus changes. The mean age of presentation was 56.1 in multicenter study called Radiance, but in Indian population it was seen a bit more lower age, 47.9. And coming to the natural history, initially it presents as a subretinal heme without subretinal fluid. And then in the second stage, the heme resolves, leaving and fibrosis happens, and there will be some variable amount of pigmentation, which is called fugue spot. Then the CNV regresses, leading on to a area of choroidal atrophy. In a study done with a 10-year follow-up without any treatment, this myopic CNVM can lead to a vision deterioration to 20/200 or worse in 96% of the people. And 35% with myopic CNV in one eye can develop CNV in the fellow eye. So we need to keep a close watch on the other eye too. Mechanical theory is already being dealt with. AP anteposterior elongation leads to breaks in the RP Bruch's choriocapillaries, which can lead to CNVM. And also choroidal filling delay can lead to choroidal ischemia, which can again lead to upregulation of angiogenic factors and then CNVM. There's also a genetic theory explained. The risk factors are high-grade myopic maculopathy, Lacos cracks, choroidal thinning, higher aqueous humor levels of inflammatory cytokines such as interleukin 6 and 8. The patient can present with decrease in vision, central scotoma, or it could be a very mild symptoms like a metamorphopsia. The most challenging part in the management of myopic CNVM is the detection part, because it can present with a very subtle changes like a small, the choroidal neovascular membrane could be very small with very minimal exudation and hemorrhages. It doesn't have a typical picture of an age or later macular degeneration. A type 2 CNV is the most common type seen. So we have to resort to the multimodal imaging to make a diagnosis and to follow up these patients. OCTA shows active lesions are seen as a primarily interlacing pattern, and in the inactive lesions have a tangled appearance. I will go through a few cases. This is one of such cases with the fundus. The patient had some metamorphopsia, not much drop in vision, and you could see a hyperreflective lesion above the RP with a single intraretinal fluid, and OCTA shows a small CNVM, and FFA shows leakage. So the FFA can be used to assess the activity of this neovascular membrane. A subtle leak on the FFA may be the only sign in these patients. There could be other pathologies coexisting, such as macular schisis. So in the left eye, you can see a neovascular membrane with a lot of cystic spaces and schitic area. So so one could use FFA to know the size, location of the lesion, and also to assess the activity of the CNVM. The differential diagnosis include macular hemorrhages from the Lacos cracks, dome-shaped maculopathy, inflammatory CNVM. So our main aim is to detect it early and treat before the fibrosis sets in. So early detection and early treatment is the key. Laser photocoagulation and PDT has been tried with the limited vision improvement. Anti-VEGF is the first line treatment. So this patient underwent 2 injections in 2020, and you can see the fuzzy borders of the hyperreflective material become well defined, and the resolution of the fluid, and OCTA also shows resolution of the membrane. But the presence of this flow signals in OCTA doesn't mean the disease is active. So we can use FFA to know for sure the CNVM is inactive, so that we can stop the treatment. This is the second patient who also had a resolution of the fluid, but the schisis is still persisting. So RADIANCE is a randomized control study done with ranibizumab in myopic CNVM. They found a mean improvement of 10 letters, and what's striking was the mean injection needed was only 3.5, and they followed a strategy of 1 injection followed by PRN without any loading dosage. And in the study, from the month 6 to 12, more than 60% of the patients receiving ranibizumab did not receive any injections. And real-world data also showed almost similar results. 52.2% needed only 1 injection, and nearly 90% needed only less than 3 injections during 12 months. Aflibercept also showed almost similar results with mean injection of 4.2. Bevacizumab also found to be non-inferior to rasumab. So in short, this can be managed with a injection followed by a PRN regimen without a loading dosage. The factors affecting treatment outcomes include older age. The poor prognostic factors include older age, sub-4V location of CNV, large lesion size, poor presenting visual acuity, thinner choroid, and Lacos cracks. The next problem that we expect is the recurrence, and in a 2-year study, they found the recurrence to be 23.3%, and the majority of the recurrences occurred during the first year. In the post-RADIANCE observation study also, the recurrence after 1 year was only 10%. So the most of the recurrences in the first year, and the main predictor for the recurrences, the number of injections needed to control the initial disease. If it is high, there is more chance of recurrence. The higher the baseline CNVM size, the more chance of recurrence. The additional injections needed to treat this recurrence were only 1.9, and the final visual acuity was also similar in both the cases who had recurrence and non-recurrence. So we can use a treatment regimen of 1 injection followed by PRN, stricter follow-up in the first year. And most of these studies have shown that the vision has persisted, had the visual gains persisted for almost 3 to 5 years, but some patients started developing drop of vision after 5 years. The important reason found for this drop in vision is because of the choroidal atrophy that sets in beyond this stage. And in conclusion, usually younger age group are affected compared to the age-related macular degeneration. And the key point is they have very subtle changes, so you have to be very careful, especially in the background of other coexisting pathologies. It's very difficult to pick up these changes, so we have to resort to this multimodal imaging. And anti-VEGFs are found to be very efficacious, and the recurrence and the number needed were very low compared to a age-related macular degeneration. And closer follow-up in the first year, then you can relax the follow-up. Early detection and early treatment is the key for the treatment. And even in the patients with center scarring and with the eccentric CNVM, parafoveal CNVM, if they recur also, it's better to treat them, because the patient requires only very few injections, and they can have a large scotoma if left untreated, because most of the size, the vision may be already be compromised. Thank you.
Thank you for the presentation. Can you answer a question for? Can you just explain the basic differences between myopic CNVM and AMD CNVM for the benefit of the audience, treatment and management wise?
First of all, they present with very subtle signs. The picking up part is the most difficult one. The number of injections needed are very less. It's almost half.
I think meanwhile Dirish can start his talk.
Compared to the CNVM secondary to the age-related thing, and most of them, the recurrence is also very low. So it is easier to treat. Most of the anti-VEGF work equally well. So there is no confusion between the choice. Just that they need to be started early and picked up early before the. And most of the studies, many people might be worried about the peripheral degenerative changes, whether the patient will go in for RD and etc. when you treat them. But most of the studies have not shown any, severe, complications such as RD in their studies. So it's really, anyone can be confident in injecting this patient, just that you need to screen them for any treatable lesions in the periphery.
That brings to a question: if you see a lattice and the myopic CNVM, will you treat the CNVM first or will you treat the lattice first?
If it is a break, if it's a lattice alone, pigmental lattice, I don't think it's a must to treat. But to be on the safer side, if you feel that the patient is elderly, the PVD is happening or something, it's better to treat. Better to be safe than having it.
Next we have a talk by Dr. Dilish on myopic traction maculopathy. Over to you, Dr. Dilish. Thank you, Kiran.
Good afternoon, everyone. I'll be talking about myopic traction maculopathy. So myopic tractional maculopathy was initially described by Phillips all the way back in 1958 as retinomacular schisis, and later on in the OCT era, Takano and Kishi described it as foveal retinomacular schisis, and in 2004, Panozzo was the first one to call it myopic traction maculopathy. Later on, so many classifications came for the same disease. Dr. Anjana described one or two of them, and the latest classification and the most useful one as of now is the Parolini's myopic traction maculopathy staging system, or the MSS. It describes not only the evolution of the disease, it also helps us in managing, making management decision. So what happens in the pathology? There are changes in the sclera. The sclera elongates and enlarges, and the vitreous liquefies and contracts, pulling it from both directions. So this causes the changes in the retina, which is stretching, schisis, detachment, and macular hole. And in the choroid, it causes thinning, atrophy, and choroidal neovascular membranes. The normal forces which keep the macula together are the centripetal forces exerted by the Muller cells, the internal limiting membrane, and the external limiting membrane mainly. And in myopic traction maculopathy, there are certain forces which act against it. There are the tangential forces exerted by the vitreous and the perpendicular forces exerted by the sclera, enlarging and elongating sclera. So the perpendicular force, as it evolves, it initially causes inner layer schisis. Later on, it goes on to cause outer layer schisis, and then the posterior pole of the macula detaches, and then the entire macula detaches. Once the entire macula detaches, the schisis cavities usually disappear. And in the tangential force, you have lateral stretching of the fovea, leading on to an inner lamellar hole first, and later on, the macula gives way and forms a full thickness macular fold. When both are there, when perpendicular and tangential forces are both present, it can have a full thickness macular hole along with the macular detachment. So coming to the staging system per se, Perroni described 4 retina patterns numbered as 1, 2, 3, 4 representing the perpendicular traction, and the foveal patterns numbered as A, B, C representing tangential traction. So as I described earlier, the stage 1 is your inner or outer layer schisis, and stage 2 is outer schisis, and stage 3 is macular detachment confined to the posterior pole, and stage 4 is macular detachment involving the entire posterior pole. And foveal patterns are your intact fovea, that is stage A, and stage B is your inner lamellar hole, and stage C is your full thickness macular hole. Additional patterns which are associated with are denoted by suffixes like plus sign for the presence or absence of epiretinal membrane, and an O for presence of outer lamellar hole, as you can see here. So describing the entire stages in the same slide, you have the tangential traction evolving along the x-axis. You have the stages that we described earlier here on the top, and on the vertical axis you can see the retinal patterns that I described earlier. Any pattern which is in a mixture of these can be described like this. Like in the stage 3BO, you would have a stage 3 which is the macular detachment, and stage B which is a small inner lamellar hole along with a small outer lamellar hole that you can see here. So that's how you describe the disease. And in the natural course, the myopic traction maculopathy is correlated more with the duration of pathological myopia rather than the age of the patient. It is initially asymptomatic, and as the disease progresses, the progression becomes faster and faster. So this because of this, you have to initially follow the patients maybe yearly or so, and as the disease progresses, you have to decrease the follow-up interval and follow them faster and faster. And surgery has to be considered for stage 3 and stage 4 and any stage C to preserve and maintain vision. Coming to the treatment aspect, initially we had only the macular buckle. From 1930 to 1980, all we had was macular buckles. Several techniques were tried, and this was technically very difficult and very risky. As you can see, the sutures are passing right at the macula, very close to the optic nerve, so the risk of perforation, submacular hemorrhage, etc. was very, very high, and it was very cumbersome. Then came the vitrectomy era. People have tried several techniques. People have tried directly lasering the macular hole with silicone oil with high success rate, but low vision, obviously. And Liu in 2002 has compared gas versus silicone oil and found that gas was better at tamponading the macula because it has high buoyancy compared to the silicone oil, and it conforms to the posterior staphyloma contours much better than silicone oil. And ILM peeling had good results for full thickness macular hole, but the risk of iatrogenic FTMH is very high when there is no macular hole initially to start with. And a recent study by Park has suggested that if you do PPV alone, the myopic tractional maculopathy actually progresses faster than in a normal eye, than otherwise. And because of these things, because of these limitations, again people started coming back to macular buckles and combined surgeries. Several newer designs came up which tried to shift the sutures away from the macula as far as possible and still give an adequate pressure at the macula. This is the Devin Moran design that we commonly see in India, and this one is the AJL macular buckle, which is the latest, which has a groove for a fiber optic cable to go in so that you can see the transillumination for adequate positioning of the. And there are also nomograms for the suture positioning based on the axial length of the patient. And outcomes of macular buckle. In 2018, Alkabis did a 16-year review of macular buckles versus PPV, and she found that retinal reattachment as well as macular hole closure was much better in macular buckle versus PPV. And Serhan, in a meta-analysis of 482 eyes, found that the reattachment rates were as high as 94% with macular buckle, which is very close to our retinal detachment results even, and FTMH closure was around 72%. So compiling the lessons from the literature, vitrectomy is much easier to perform, but the recurrence rates are higher and risk of iatrogenic macular hole is higher. Macular buckle has a higher success rate, but it is technically very difficult, but macular buckle alone cannot close a macular hole. So we have to tailor the solutions to the problem. Parolin et al. Once again in 2021, they studied the outcome of PPV versus maculobuccal and combined surgery of around 157 patients at different stages of myopic traction maculopathy. So she found that PPV addresses the tangential traction, that is the foveal pattern, and maculobuccal mainly addresses the perpendicular traction, that is the retinal pattern. So this is management which is described in a single slide. So in initial stages 1A and 2A, you can safely observe the patient, and macular buckle is the treatment of choice for stage 3A and 4A, where perpendicular traction is the main component, and 1B and 1C, your PPV is the treatment of choice because the main component is tangential traction. And at the intermediate stages, you have the option of treating the patient with macular buckle first, and later on, if the patient is symptomatic, they can be added with vitrectomy. And in stage 2C, 3C and 4C, your treatment of choice would be a combined surgery. So other considerations while deciding about surgery is atrophy and amblyopia. Atrophy, the presence or absence, it does not, it influences the decision whether to treat or not to treat. It does not influence the choice of surgery. So treating a detachment even in the presence of atrophy can improve some little bit of visual function. And amblyopia is another thing which you have to carefully keep in mind, because anisometropy is very common. You have to ask carefully for a recent drop in vision, and when there is a doubt, you have to observe the patient for a few months and document a worsening of vision and OCT. So in the future, the incidence of this disease is going to rise as myopia is on the rise, and safer techniques and nomograms are coming up, which gives younger vitreoretinal surgeons also confidence to attempt this difficult procedures like maculobuccal. Thank you.
Thank you, Dilish, for that wonderful presentation of myopic traction maculopathy. One question I would just like, do we have any questions from the audience? Just one question from my side, like when most of the general ophthalmologists may be seeing advanced myopia. So what is your advice? How do you follow up? Like what is the red flag that tells that there is a myopic traction, or do you want to do OCT in all cases of myopic macular degeneration?
When you have a staphyloma in these patients, it's better to do, and vision is not correlating to the disease. Definitely, when this thing is your vision is not correlating with your clinical picture, definitely you have to do an OCT. Otherwise, in the initial stages when the vision is not affected, anyway we are going to observe them only. So just for that matter, I wouldn't ask a general ophthalmologist to refer to a VR surgeon or take an OCT, but if definitely vision should be our marker, I feel. Thank you.
Thank you, Dr. Dilish. Next, we have Dr. Prakash sir on stage. Sir will be speaking on the cutting-edge techniques of vitreoretinal surgery in myopic eyes. Over to you, sir.
Thank you, Anjana. So my talk is on newer techniques what we are doing in myopic retinal surgery, and my job has been made very much easier by Dilish because he has described most of the surgical techniques that's currently used for myopic traction maculopathy. So myopic eyes are a peculiar group of eyes where they are at risk for many complications compared to normal eyes. There are complications which are specific to myopia, like myopic traction maculopathy, which you don't see in normal eyes. But all other complications that normally happen, like an ERM, macular hole, or a retinal detachment that happens in normal eyes, also can happen in myopic eyes. But when they happen in a more severe level, and they happen earlier in younger age group. So that is the anatomic problem that we face with myopia. And surgically, it is very challenging to do surgery in VR surgery in myopic eyes, mainly because of these factors. One is the high axial length. So many times we cannot reach the posterior pole for the instruments may not reach there. The posterior staphyloma and an abnormal curvature. The radius of curvature is very less compared to normal eye. So when you move instruments, there is a high risk of touching the retina. Thin and atrophic retina makes it difficult, especially to do laser. RP atrophy, if it is there, you cannot do laser. And also it decreases the contrast so that we cannot see the retinal layers like you see in normal eyes. And degenerated vitreous, many of these eyes have schitic vitreous, which leaves many layers of vitreous. Even if you feel there is a PVD, after you induce one PVD, then you will see there are multiple membranes, still vitreous membranes remaining. Then they have thinner sclera and abnormal scleral fibers architecture, which makes a wound closure difficult. And as I told earlier, the lack of contrast at posterior pole. So we'll see few of these problems and how do we used to tackle previously and how do we tackle nowadays. So increased axial length is for all of us, that's the biggest problem. So initially we used to use 20 gauge instruments because 20 gauge instruments are stouter, so they are also longer, so we could easily access the posterior pole. If you want to use small gauge instruments, remove the trocar so that you will get another additional 0.5 or 1 millimeter extra length. That will increase the length of the instrument. And another thing is to reduce IOP of the globe and press with the finger while the surgeon is operating. The surgeon presses on the globe through his the active instrument so that the globe the sclera goes down and you can reach the posterior pole. Nowadays, all companies are coming with newer instrumentation. This is something developed by Topcon office system, where they have this kind of bend. The biggest problem was when you have to align more vertically the instruments than in a normal eye. So when you align vertically, the biome lens, which we use, a non-contact viewing system, comes in touch with the instrument, and then it becomes very difficult during surgery. So to avoid that, they have created these bent instrument, longer instruments, which are bent, so that the viewing system which is on top does not interfere in your surgery. Another way is to have long shaft instruments. These are again being developed by Alcon and they are launching it this year in India. So this also will take care of this problem. Then the other problem is epiretinal tissues visualization. So what we have been traditionally doing is chromovitrectomy, that is using dyes to identify various layers of the retina or the vitreous. So we have to use always tissue specific dyes. For vitreous we use tricot. We can see the multiple layers of vitreous, and for ILM in myopic eyes we routinely use BBG, but in ILM eyes it is in myopic eyes ILM does not stay in well with BBG and you may have to use ICG. ICG is slightly toxic than BBG, but still it is better to use ICG, and trypan blue is better for ERM. Newer techniques, we have intraoperative OCT microscopes mounted with OCT, 3D imaging techniques, which will make it better. Also, the other biggest problem is we usually inject with syringes which don't have a controlled injection. So many dyes get inside the macular hole, causing toxicity. So now we have newer devices which will have a controlled mode of injection and thereby avoid the toxicity. And we have also microscope mounted filters. We use amber filter for if you are using a billion green dye or a green for other dyes. And ILM peeling, again, is technically very difficult in myopic eyes. Mainly one thing, it is difficult to visualize. Second thing, it is your own instrument will block the view. While you are doing, you cannot see what is happening under your instrument. So it is better to start from the inferior or temporal quadrant so that you can see it better. And it is when you have to use an inverted flap or something, the flap usually goes away. So you can use a PFCL to reduce the mobility of the flap. But nowadays we have, for beginners at least, there are instruments like finesse loop which can be used, which are very safe. You can scratch on the retina and raise the flap so that you can easily get an access to the ILM. Vitreous shaving again becomes difficult because of the risk of lens touch. So whenever there is a little cataract, it's better to take care of the lens, tackle the lens along with it. Sclerotomy leakage, we have now 27 gauge instruments which are very small gauge, as well as walled cannulas, which is again very useful in this case. This slide has already been covered by Dilish. This is from the Barbara Parolini classification. So basically what you have to understand is myopic maculopathy. There is two things happening. One is a tangential thing which will cause epiretinal changes like macular holes, lamellar holes, or full thickness macular holes, and that is tackled by vitrectomy. Then when you have in vertical anterior posterior change, that is the schisis developing, that is tackled with macular buckle. If there is a combination of these two, you will have to use a macular buckle along with vitrectomy.
So this shows actually the natural course of myopic maculopathy. This is a picture on the top in 2019. Then you can see there is a full thickness macular hole that is slowly developing, and then few years later there is anterior posterior traction also developing. So that's the way it usually progresses. This was a lady who had 612 vision in right eye way back in 2018. Left eye had that time right eye had a mild schisis, as you can see here. But the left eye had a myopic traction maculopathy with a detachment, that is more of an anterior posterior thing. So an vitrectomy was done in that eye with gas injection, and that eye settled and had a postoperative vision of 636. Unfortunately I don't have the pictures of that case, but later in 2023 she presented with drop of vision in the right eye, which she had 612 vision at that time. Now you can see there is again a macular detachment here. We searched for a break on OCT. OCT is very challenging in these cases. Many times due to multiple reduplication of echoes, you won't be able to interpret OCT correctly. So here we couldn't actually make out where the macular hole, where the hole was which was causing the detachment. So here, since the problem was a macular detachment due to an epiretinal problem, that's a hole, we had decided to do a vitrectomy in this patient. So as I told her, usually it's if the lens is clear, it's better to preserve the lens because other eye is also myopic. So if you remove the cataract, then it becomes difficult to correct the patient after the surgery. So here the patient had a significant cataract, so it was decided to do a cataract surgery along with it. That also makes surgery very easier for us because without touching the lens, we can do base excision and other aspects of the surgery. So you can see the large posterior staphyloma here. This is the edge of the staphyloma and the myopic changes. So a complete vitrectomy was done with the base excision. The challenge was in finding the break, where exactly the break is. So actually retinotomy was made, and brilliant blue-green was injected into the subretinal space. You can see the dye going under the subretinal space. Care has to be taken so that it doesn't go under the macula too much, and it also has to be completely evacuated so that it does not cause a macular dye. If left behind, it can cause macular toxicity. So once the subretinal dye is there, just gently over the disc area, wherever you are suspecting there is a break, you can just aspirate with the float needle. And as you aspirate, you can see the dye coming from that area. So that is the break because of the lack of contrast, because you are seeing bare sclera there. So you cannot normally make out the break unless you use this technique. So here I can see the dye is coming out through the hole, and so I identified the break which was cauterized, and then the surgery was completed after doing complete internal limiting. All the vitreous remnants were removed. And again here the problem is like many times you cannot reach the posterior pole, especially once you do a fluid air exchange, it's very difficult. So here instead of the biome you can use contact lens. So the contact lens will avoid the touching of the instrument with the biome which is above the eye. The contact lens, since it is very close to the eye, you will have still working space for your long instruments. So the main thing is to remove all the traction. When there is no macular hole, then we do a fovea sparing ILM peeling, because ILM may be the only thing that is preventing a macular hole becoming full thickness in this eye. So we don't peel the ILM over the macula. A fovea sparing ILM peel is done. Meticulously ILM is peeled, and then a fluid air exchange is done. Complete dye is removed and the gas is injected. So that is the post-op picture of the patient. Patient recovered back 612 vision. And this is again a patient. Here you can see that you don't have a macular hole, you have only a submacular detachment. So here a macular buckle is being done. We are using a Morin Davin T implant. The biggest challenge is for retinal surgeons is to hook the inferior oblique. We usually don't have to hook the inferior oblique. We only do the recti. But here you have to take the inferior buckle. It has this element is passed under the inferior oblique, and here I am putting a infusion cannula as well as a chandelier, as a light pipe, only to visualize the position of the buckle. No vitrectomy was done, no internal procedure was done, only to look at the position of where the buckle is going. So you can see the mound that is developing where I place a macula. So that helps me to position the buckle directly under the macula. So that's a post-operative picture on the right side. You can see it also decreases the myopia by about 2 diopter. But only problem is long-term studies. We have to see what happens to because already they have thin choroid. So the compression might cause more choroidal thinning and might cause an RP atrophy. So long-term follow-up is required. What happens to the vision? But right now the patient is doing well. This is again one more patient. Here you can see there is a macular hole as well as a detachment. So here the combination of both factors, anterior posterior as well as a traction is happening. So these are ideal cases for combined surgery where you will have to do a vitrectomy as well as macular buckle. So initial thing is to place a macular buckle. So as I told earlier, the inferior oblique is hooked, and this Morin Devin T buckle has two elements. One is a 240 like thing which is passed under the inferior oblique. Then it has got a T-shaped element which is which we place under the macula. So that is like doing any other buckle. So here I am doing the vitrectomy. You can see the large area of RP atrophy, and complete vitrectomy is done and ILM peeling is done. Here there is a macular hole already, so a complete ILM peel is done without fovea sparing. It's involving the hole. We have done an ILM peeling, and after the vitrectomy, the buckle is positioned. You can see the mount developing. The buckle is positioned. You can see the mount where this is the area where I am placing the buckle. We can see it. Once you confirm the position of the buckle, it is sutured onto the sclera, and the 240 element is tightened so that it is held from the other side also. After that, it's only a routine surgery. You do a fluid air exchange and put C3F8 gas. So these are few cases of myopic traction maculopathy which shows progression. You can see here it was initially treated for a CNVM, then developed a traction macular hole, then underwent vitrectomy. Then this is again one more case which has undergone vitrectomy. These are few cases done vitrectomy alone without buckle because there is no macular hole here. So this is one more case. So to conclude, we have to understand that these eyes are peculiar eyes where they have a higher risk compared to normal eyes to lose vision, not only due to other problems but due to retinal and macular issues also. So early detection is very important. You have to judiciously use whenever you see a patient of myopic macular degeneration, and if you have patient is complaining of any visual symptom, don't ignore it. Always do an OCT and see if there is anything going wrong. VR surgery is challenging, but newer technologies are making it better and more successful for these patients. Thank you.
Thank you, Dr. Prakash, for that excellent presentation. Any questions from the audience? So by that, we are coming to the end of our session. Thank you all for your patient listening. Thank you so much.